Invasive early stage breast cancer, a review of staging. T1N0 is stage 1A. T0 to T1, N1 MIC is stage 1B. T1N1 or T2N0 is stage 2A. T2N1 or T3N0 is stage 2B. Immunohistochemistry or IHC positive, treat as node negative. What about N1 microinvasive? Soft N1 would consider adding a high tangent. Don't do partial breast. Don't necessarily need to add chemotherapy, although you can consider it. Don't do regional nodal treatment. Endocrine, generally just do it sequentially. Do invasive ductal and DCIS in if that is there. If focal, then that's okay, don't need to, but extensive DCIS, then use DCIS 2 millimeters and re-resect. In terms of management for early stage invasive breast cancer, obviously option number one would be lumpectomy and nodal evaluation followed by chemotherapy if it's indicated, followed by radiation, followed by hormonal treatment if indicated. Lumpectomy, you need an adequate margin, which is defined as no tumor on ink. You re-resect if possible and if necessary. Nodal evaluation, if they're clinically node 1 positive, then you do an FNA of the node. If it's positive, then they get an axillary lymph node dissection. If it's negative, or if they're clinically node negative, then you do a sentinel node biopsy. If sentinel node biopsy is negative, or only micromets, then you don't need an axillary nodal dissection. If the sentinel node biopsy is positive, then no axillary nodal dissection. If it's a T1, T2 tumor, clinically node negative with less than or equal to 2 positive sentinel nodes, if the nodes are not matted, if there's no ECE and the plan is for post-op radiation and the patient did not have prior neoadjuvant chemo. Otherwise, a sentinel node biopsy and you're not meeting any of those criteria, then you do an axillary nodal dissection. Chemotherapy for the NCCN guidelines, you do chemo if they're clinically node positive. If they're node negative, then these are the situations in which you would need chemotherapy. ER positive, HER2 negative, less than half a centimeter, you do not need chemo. If they're ER positive, HER2 negative, and it's greater than 0.5 centimeters, do an oncotype. If it's low, meaning basically 1 to 17, no chemo. 18 to 30, shared decision making. 31 or greater, do chemotherapy. If you have an ER negative, HER2 negative tumor, less than half a centimeter, there's no chemo. If it's greater than half a centimeter and up to 1 centimeter, consider it. If it's greater than 1 centimeter, do chemo. Any HER2 positive tumor less than 1 centimeter, consider. Anything greater than 1 centimeter, do chemotherapy. Regimens, again, HER2 negative, get dose dense AC. That's adriamycin 60 milligrams per meter squared and cyclophosphamide 600 milligrams per meter squared. Dose dense means it's every 2 weeks times 4 cycles. Then followed by T, which is paclitaxel, 175 milligrams per meter squared, again every 2 weeks times 4 cycles. A repeat, dose dense AC plus T is for HER2 negative disease. That's adriamycin 60 milligrams per meter squared and cyclophosphamide 600 milligrams per meter squared every 2 weeks times 4 cycles, followed by T, which is paclitaxel, 175 milligrams per meter squared every 2 weeks times 4 cycles. Alternatively, if there are cardiac issues and you want to avoid adriamycin, you can do TC. This means docetaxel, 75 milligrams per meter squared, and cyclophosphamide, 600 milligrams per meter squared every 3 weeks times 4 cycles. Note that T in TC is docetaxel. In AC plus T, it's paclitaxel. The paclitaxel dose is 175. The docetaxel is just 75. HER2 positive disease, AC, again, adriamycin 60, cyclophosphamide 600. This time, Q 3 weeks times 4 cycles. And then T, which is again paclitaxel. It's at a lower dose though, now at 80 milligrams per meter squared every week times 12 weeks. Concurrent with trastuzumab, 4 milligrams per kilogram first loading dose and then 2 milligrams per kilogram per week for a year. Alternatively, again, if the patient has cardiac issues and you want to avoid adriamycin, then you do TCH, docetaxel, carboplatin, trastuzumab. Radiation, 1 month after the last dose of paclitaxel if the chemo is given, can be standard fractionation or hypofractionation. New Astro 18 guidelines, hypofractionation is preferred if you're not targeting the nodes. Any age, any stage, as long as it's not covering the nodes. Volume 105 less than 10 to 15%, max dose less than 107 to 110%. If the sentinel node biopsy shows no nodes, you can treat with tangents only. Again, the superior borders the inferior clavicular head. Note that EORTC and MA20 had high risk node negative group that could be considered for regional nodal radiation if the examiner pushes, like large, medial tumor, young age, extensive LVSI. If you have 1 to 3 positive nodes, then most of these patients will get regional nodal irradiation with level 3 and superclav plus or minus IMN plus or minus levels 1 and 2. If they're a Z11 candidate and they didn't get an axillary nodal dissection, but they're high risk and you're giving RNI, would contour levels 1 and 2 and make sure they're covered between the tangents and the third field. If they got axillary nodal dissection, then there's no need to intentionally make sure levels 1 and 2 are covered unless there was gross ECE, high burden of nodes, etc. There's a continuum of benefit. The lowest risk patients may only need high tangents. Again, if sentinel node biopsy shows 1 to 2 nodes and meets ACOSOG Z11 criteria, then axillary lymph node dissection can be omitted and it's a nuanced decision. They fit Z11 and low risk, meaning a T1 tumor less than 2 centimeters, only 1 positive node, ER positive, LVI negative. You can do whole breast and high tangents where the superior border is at the inferior humeral head. If they are higher risk and you're not comfortable using Z11, meaning they're 2 positive nodes, they're young, they're LVI positive, they're ER negative, you can do regional nodal radiation of the full XL and the superclav. You can justify with Amorose, MA20, EORTC. If they're a sentinel lymph node biopsy candidate and they're not a Z11 candidate, they should have gotten an axillary nodal dissection. If they refuse axillary nodal dissection, then they need full axilla and superclav radiation. If the patient has 4 or more positive nodes, then they all get RNI. Indications to intentionally cover levels 1 and 2 after axillary nodal dissection. Again, make sure they're in the tangents. Generally, it's just the undissected axilla. This is for intentionally targeting the rest of the axilla after axillary nodal dissection. If they had gross ECE, if there's a greater than 50% nodal ratio, if there were less than 10 lymph nodes resected. Indications for a superclav or level 3 field are 4 or more positive nodes, or 1 or 3 lymph nodes. You could make an argument for treating with 1 to 3 nodes positive using MA20. Indications for IMN, clinically or pathologically positive, elective IMNs if there's positive axillary lymph nodes with an inner quadrant primary. Most randomized controlled trials included IMNs in regional nodal radiation. Boost for 2018, ASTRO guidelines, you omit for age greater than 70 with ER positive, low intermediate grade tumors with widely negative margins greater than 2 millimeters. You give it for age less than 50 or positive margin, or age 50 to 70 with high grade features. All others are shared decision making. Endocrine treatment only for ER positive disease. Note the Atlas trial showed a 3% disease specific survival benefit for 10 versus 5 years. Initially premenopausal tamoxifen 20 daily times 5 years, you can consider ovarian suppression. Then if after 5 years they remain premenopausal, you consider another 5 years of tamoxifen for a total of 10. If after 5 years of tamoxifen they become postmenopausal, then add an AI like anastrozole for another 5 years. If they are initially postmenopausal, you do an AI like anastrozole times 5 years, and you consider an additional 5 years. Option number 2, mastectomy plus sentinel node plus axillary plus or minus axillary lymph node dissection, plus or minus chemo, plus or minus radiation, plus or minus hormonal treatment. If sentinel node biopsy is positive, then you do an axillary lymph node dissection. You could technically omit if you're planning for adjuvant radiation per Amorose, since 20% had mastectomy, but NCCN says axillary lymph node dissection. Post-mastectomy indications. If there are any nodes positive, then radiation to the chest wall and regional nodes. If positive margin or T3 N0 only, then radiation to the chest wall. Might consider not treating T3 N0 if everything else is favorable, such as ER positive, LVSI negative, not grade 3, etc. Option number 3 is lumpectomy plus sentinel node followed by tamoxifen and no radiation. This is for selected patients only, i.e. those that are greater than 70 with a T1 tumor, node negative, ER positive, margins negative, willing or able to take 5 years of tamoxifen, willing to accept a modestly higher local recurrence risk. NCCN says greater than 70, T1, N0, ER positive, getting tamoxifen. Consider a category 1 option now by NCCN. This is based on CALBG and Prime 2 trials. The risk of recurrence with tamoxifen alone is approximately 1% per year. In terms of evidence, looking at the role of breast conservation versus mastectomy, there are 6 large randomized control trials that have shown equivalent overall survival and local control between breast conservation and mastectomy, 48% at 20 years. Um, Things like NSABP 06, mastectomy versus lumpectomy alone versus lumpectomy plus radiation. Radiation improved ipsilateral breast tumor recurrence from 39% lumpectomy alone to 14% lumpectomy plus radiation. There are multiple randomized controlled trials looking at lumpectomy versus lumpectomy plus radiation, such as the EBCTG meta-analysis. 10-year local recurrence, 35% versus 19% for lumpectomy versus lumpectomy plus radiation for a 16% difference, with a 4% difference in disease-specific survival and overall survival. Again, sentinel node biopsies indicated for a clinically negative axilla. The negative predictive rate or negative predictive value is 97%. The false negative rate in a sentinel node biopsy is around 10%. Clinically node negative patients have pathologically node positive upon sentinel node biopsy about 20 to 40%. Role of axillary lymph node dissection are our first couple of trials. The first one is ACOSOG Z0011 Giuliano. This is about 850 T1 to T2 clinically node negative breast cancer patients who had lumpectomy. They had 1 or 2 sentinel node biopsies that were positive. Anybody that had a mastectomy was excluded from this trial. Anybody who had extracapsular extension on their nose was excluded. They either got a completion axillary nodal dissection or no axillary nodal dissection. After that, everybody got whole breast radiation with tangents. Radiation to the supraclav or targeted axillary radiation was prohibited. 97% had adjuvant systemic therapy, either chemotherapy or endocrine therapy. There was no difference in any cancer outcomes, and the overall survival was non-inferior. At 10 years, the overall survival actually with axillary lymph node dissection was worse. 83.6% 10-year overall survival for axillary nodal dissection versus 86.3%, which is statistically significant. They're enantiomers of each other. 83.6 versus 86.3, 10-year overall survival. Only 1 local regional recurrence between years 5 and 10. A median of 17 nodes were removed with the axillary nodal dissection. On axillary nodal dissection, 21% had greater than or equal to 3 positive nodes. Bottom line is axillary lymph node dissection is not required after a positive sentinel lymph node biopsy. In T1 to 2 breast cancer with 1 to 2 positive sentinel nodes receiving whole breast radiation and adjuvant systemic treatment, at longer follow-up, overall survival was non-inferior and actually favored the sentinel node biopsy-only group. The second trial is JAGZ's radiation portal analysis, which is published in JCO. She found in ACOSOG Z11, 50% of those patients who did not have axillary nodal dissection got high tangents, and 20% actually had regional nodal irradiation. Third trial is Amaro, Stonker, Lancet Oncology 2014. This is 5,000 patients, again, clinically T1 or T2, node negative, either had breast conservation surgery or mastectomy. So that's a big difference. In Amaros, they were allowed to have mastectomy. Lobular histology was allowed. This was a non-inferiority trial. Again, after breast conservation or surgery, they had a sentinel node biopsy. If the sentinel node biopsy was positive, they either had a completion axillary nodal dissection or they had regional nodal irradiation to the axilla, levels 1 to 3 and medial supraclav. So that's a difference. In ACOSOG, it's either completion axillary nodal dissection versus nothing and then whole breast tangents. In Amaros, it's axillary nodal dissection versus regional nodal irradiation to the axilla and the medial supraclav. In all, you had whole breast radiation. There was optional RT to the chest wall for mastectomy. If in the axillary nodal dissection group and there were greater than 4 nodes positive, regional nodal radiation was allowed to a dose of 50 gray. For non-inferiority, the radiation group must be less than or equal to 4% and axillary nodal group 2%. There was no difference in cancer outcomes. Both were approximately 1% axillary recurrence at 10 years. There was a higher rate of lymphedema in the axillary nodal dissection arm, 28% versus 14% at 5 years. In service, we'll say 23% versus 11%. 27% of the nodes were positive on further dissection. That's tested. So almost a third of those patients in the axillary nodal dissection group had further positive nodes. The bottom line from Amaros is that axillary nodal dissection is not required, again, in T1 to T2 sentinel node biopsy positive when radiation is directed to the axilla. Overall survival and distant metastasis-free survival are non-inferior with axillary nodal dissection and with radiation. Overall axilla recurrence was low at 1% or less in both groups. There were more secondary contralateral breast tumors with radiation. The next trial is IBCSG 2301, Galimberti, Lancet 2018. This is looking at the role of axillary nodal dissection after axillary lymph node biopsy or sentinel node biopsy with micrometastases. So this is about 930 patients, 1 to 2 micromets, which again, N1 MI is less than or equal to 2 millimeters on a sentinel node biopsy. Similarly, the tumors were T1 to T2. So they had a sentinel node biopsy, they had 1 to 2 nodes with micromets. They were randomized to either completion axillary lymph node dissection or observation. The findings from this is there was no difference in local regional recurrence, disease-free survival, or overall survival, depending on whether they got a completion axillary nodal dissection or just observation. Lymphedema was 13% for the dissection group versus 4% observation. 13% had positive nodes on further dissection. So fewer than Amaros, which makes sense. It's just micromets. Sentina trial, sentinel lymph node is reliable if it's performed prior to neoadjuvant chemo. However, the false negative rate is higher, 24% for 1 node, 14% for 2 nodes after neoadjuvant chemo. ACOSOG Z1071, Bougie, JAMA 2013. Findings from this are that sentinel node biopsy after neoadjuvant chemo did not meet the pre-specified false negative rate threshold of 10% for reliability. The dual radio tracer technique in greater than or equal to 3 nodes taken improves the accuracy, but still did not meet the threshold. Omission of radiation, there are 2 trials that you should be aware of. CALBG is the first one, Hughes, JCO 2013. This is about 630 patients. They were older, they were 70 years or older. They had T1 tumors, ER positive, any grade, but had lumpectomy. They were randomized to either tamoxifen with radiation, 45 grade plus a 14 grade boost versus tamoxifen alone. Radiation improved local regional recurrence, but there was no change in overall survival or distant mets. 10-year local regional recurrence was 10% versus 2%. 10-year distant mets was 5% in both arms. 10-year overall survival was approximately 67% or 2/3 in both arms. Only a third had sentinel node biopsy. The bottom line from that trial is whole breast radiation in elderly patients with low-risk tumors improves ipsilateral breast tumor recurrence, basically dropping it from about 10% down to 2%. The risk of ipsilateral breast tumor recurrence continues to rise on follow-up, but there's really no overall survival or distant metastasis benefit. Prime 2, Kunkel, 2015. This is around 1,300 patients. They were a little bit younger. They were either 65 years or older. They had T1 to T2 tumors, less than or equal to 3 centimeters. All were ER/PR positive, greater than 1 millimeter margins after lumpectomy. 1 of either grade 3 or LVSI are eligible, but not both. 12% were T2, 3% were grade 3. They're randomized again to tamoxifen plus radiation, 40 to 50 gray. 15 to 25 fractions are tamoxifen alone. 16% had a boost. The 5-year ipsilateral breast tumor recurrence was 4% without radiation. Versus 1% with the radiation. They tested on this 4% without radiation. So meaning the tamoxifen alone group had a 4% 5-year ipsilateral breast tumor recurrence rate. The 10-year was 10% with the tamoxifen alone versus 1% with the radiation. ER low, 10% ipsilateral breast tumor recurrence was like 18.8%. There's no difference again in overall survival or distant mets. 10-year overall survival was 80%. Once again, Prime 2's bottom line is that whole breast radiation in elderly patients with low-risk tumors improves ipsilateral breast tumor recurrence but has no benefit in overall survival or distant mets. Boost trial, several studies, most showing a modest local control benefit to a boost. The main one you need to know is EORTC Bartolink. Patients got a plus or minus 16 grade boost. Local failure at 20 years, 13% versus 9%, so there's a 4% benefit with the boost. Statistically significant for all ages, but the absolute value decreases with increased age, so if you're older than 60, there's really not much benefit. There's also an increase in fibrosis from 2% to 5% associated with the boost. Now onto the trials looking at the role of hypofractionation. Per ASTRO guidelines, basically everybody gets hypofractionation unless you're targeting the nodes. NCIC, OCOG Ontario, or the Canadian Whelan hypofractionation has 1, 2, 3, 4 patients, stage 1 to 2, so T1 to 2, N0, negative margin, all had lumpectomy, and interestingly, all had axillary lymph node dissection. There was a less than 25 centimeter separation, 107% hotspot, 11% got chemo, 40% got tamoxifen. You need to know basically what are the doses that they randomized to. And they randomized to the Canadian dose, the weird one, 42.56 gray and 16 fractions versus 50 gray and 25 fractions. No boost for either arm. 5-year local recurrence was 3% for both arms. 10-year local recurrence was just doubled, 6% for both arms, except for grade 3, which was 5 versus 15% local regional failure with hypofractionation. There was good to excellent cosmesis in both arms at 70%. Bottom line is that hypofractionation is non-inferior to conventional, but perhaps not for grade 3, question mark. Next trial is UK START A and B. This is around 2,200 patients. Now higher tumor size, so PT1 to T3, node N0 to 1. Some had breast conservation, some had mastectomy. 20% had positive nodes and received chemo, 40% got a boost. START A is broken down as follows: 50 and 25 versus 39 and 13 versus 41.6 and 13. START B, I think, is the one you really need to know. That's 50 and 25 versus 40 and 15. The 10-year local regional recurrence was 4 to 6%, which was not different. There were less cosmetic changes in the 39 gray and the 40 gray groups. The hazard ratio is 0.77. There was a statistically significant improvement in cosmesis with the 40 and 15 and 50 versus 50 and 25 in START B, so 77% had good cosmesis. In the 15% that had radiation to lymph nodes, there was no difference in arm and shoulder toxicity at 10 years and no difference in heart or lung toxicity. The bottom line from the START A and B trials is that hypofractionation results in favorable outcomes and low toxicity. Late cosmetic effects are reduced. There's no suggestion of worse outcomes in grade 3, as in Ontario Whelan trial. A sub-analysis should favorable outcomes in all groups, including chemo, no positive at any age. Next is RTOG 1005. This is evaluating the role of hypofractionation with concurrent boost versus standard and higher risk group than NCIC. These patients had neoadjuvant chemo, high-grade LVI, young age, ER negative, etc. The UK FAST trial was 50 gray and 25 fractions versus 30 gray and 5 fractions once a week versus 28.5 and 5 fractions once a week. All of these were whole breast. The 28.5 gray once weekly was similar in cosmesis and disease control. Next trial is UK Fast Forward. This is almost 4,000 patients, PT1 to 3, N0 to 1, M0 after breast conservation surgery, 93%, or mastectomy. They were randomized to 40 gray and 15 fractions versus 27 gray and 5 fractions, 1 fraction a week, versus 26 gray and 5 fractions, 1 week, which I like. All were whole breast radiation. Recurrence and survival were non-inferior across all the arms. Cosmetic effects were worse in the 27 gray. There were moderate marked skin and chest wall effects, 9.9% for 40 and 15, versus 15.4% for the 27 gray, versus 11.9% for the 26. The 27 gray arm was worse. 26 gray did have more induration in erythema versus 40 gray, but it was a less than 1% increase. Patient and photo assessments were worse in the 27 gray arm, non-inferior in the 26 and 40 gray arm. The regional nodal radiation results are pending. The bottom line from UK Fast Forward is that 26 gray and 5 daily fractions to the whole breast/chest wall is non-inferior to 40 gray and 15 fractions and has equivalent local control at 5 years. Again, 40 and 15 versus 27 and 5, 1 week, versus 26 and 5 in 1 week. 27 gray was non-inferior in local control, but the cosmetic effects were worse. Note, why were 26 and 27 gray both evaluated? The BED calc predicted a fall off at this dose point, potential for interpolation of dosing based on the results. Trials looking at regional nodal irradiation. The first is NCIC MA20. This is 1,832 patients after breast conservation and sentinel node biopsy / axillary nodal dissection and adjuvant chemo or endocrine treatment with. They either had positive axillary nodes or they were node negative but had high risk features, which was T3N0 or T2N0 and less than 10 nodes removed, and ER negative or grade 3 and LVI positive. They either got whole breast radiation, 50 gray and 25, versus whole breast plus regional nodal irradiation, meaning levels 3, superclav, IMNs, either 50 and 2s or 45 and 1.8s after breast conservation with axillary nodal dissection. 90% had chemo. There was a 10-year local regional control benefit, 7% versus 4%, and 10-year disease-free survival benefit, 77 versus 82% with regional nodal irradiation, but no difference in 10-year overall survival. Bottom line from MA20 is that regional nodal radiation improved disease-free survival, but not overall survival in node-positive and high-risk node-negative breast cancer, with a non-significant benefit in breast cancer mortality. The rate of superclav mets in the setting of N1 without RNI is less than 3%. The next is EORTC 22922. This is Portman's. This is pathologically node positive or a central or medial tumor. 75% had breast conservation, 25% had mastectomy, 45% were lymph node positive. They either had 50 gray and 25 fractions to the breast or 50 gray and 25 fractions to the breast plus the IMNs plus the medial superclav. 10-year overall survival was borderline significant. 10-year disease-free survival was significantly improved with RNI, 69% versus 72%. Bottom line from EORTC 22922. RNI to the IMNs and medial superclav results in a small benefit in overall survival and improves breast cancer mortality, disease-free survival, and distant mets in node-negative medial central tumors or node-positive breast cancer at 10 years. At 15 years, the only benefit is in breast cancer mortality. All the other become non-significant. Third trial is L'Hôpital Saint-Louis, Paris, Hennequin. Positive axillary lymph nodes or medial tumors after mastectomy. This is an IMN trial. They either got 50 gray to the chest wall and superclav alone or 50 gray to the chest wall and superclav and IMNs. There was no difference in 10-year overall survival or disease-free survival. Bottom line from this is that regional nodal irradiation to the IMNs did not improve overall survival or disease-free survival. The DCBG IMN study from Thorson was operable breast cancer with at least one node positive. Left side got no IMN coverage while the right side did. They got 48 gray and 24 fractions to the chest wall, breast, axillary levels 2 through 3 in superclav. If there were 6 or more nodes positive, then axilla level 1 was added. Better 8-year overall survival in the IMN treated patients of 72% versus 76%. Bottom line from that trial is regional nodal radiation to the IMNs improves overall survival and breast cancer mortality in node-positive breast cancer with a trend to benefit in distant mets. Last trial is CROG 0806. This is JAM Oncology 2021. Node-positive breast cancer after breast conservation or mastectomy. Either got no IMN RNI versus RNI with the IMNs. 45 to 54 gray to the chest wall, breast, axilla, and superclav. There's improved disease-free survival in mediocentral tumors. Quick note on chemo, there's a 10 to 15% 15-year overall survival and disease-specific survival benefit for premenopausal patients and a 5% overall survival and disease-specific survival benefit for postmenopausal per the Oxford Review. Tamoxifen has a 5 to 10% overall survival benefit per the Oxford Review. Margins meta-analysis by Husami in 2014 shows positive margins puts a patient at 2.4 times greater risk, unable to show that wider margins led to better outcomes.